One of the most important things I think we have is protecting our common space, our workplace here, for building a team of learners and leaders. Our learning community and the values that are demonstrated are so critically important to our everyday work and the quality of our patient care and safety. And I think there's a lot of different perspectives on how best to preserve our work area. And today we have a team from CRICO to talk about their experiences across our entire system about processes and behaviors that we can all use to foster improving our workspace. Kathy Dwyer, who's the program director for loss prevention and patient safety at CRICO, a very, very important and large responsibility is going to be with the rest of the team members. Thank you, Kathy.
Thank you. Good morning. Thanks so much for inviting us. Special thanks to Dr. Barbieri. He was the first chief to take us up on the offer to come in and do some education in this area. The title of our presentation is The Impact of Clinician Behavior, Seeing Inappropriate Behavior within the context of patient safety, employment practices, and malpractice litigation. Over the next 45 minutes, we will answer the following 4 questions for you. Number 1, first is what is CRICO's experience? Mark Horgan, Vice President of Claims for CRICO, will discuss the importance of professionalism from an insurance perspective in terms of limiting your exposure in both the medical malpractice world as well as employment-related issues. Second, what are the implications of disruptive behavior? John Reardon from the law firm of Millick, Porter & Shea will discuss potential patient safety and legal ramifications of poor behavior, which serves as a helpful reminder to all of us about the importance of behavior, that it matters. Third, what is the hospital's mission and resources available to resolve conflict? Joe Shapiro, Director of Professionalism and Peer Support, will shed light on the multifaceted approach that Brigham is taking with disruptive behavior, including how to set expectations, how to identify and help clinicians with problems, and how to hold people accountable. Finally, if there's time, how does the disruptive behavior affect the work environment? I will briefly highlight a malpractice case from the CRICO system that does not involve Brigham. It involves a case outside of Brigham, where the surgeon slipped into disruptive behavior and caused such distraction in the operating room that it led to medical error and malpractice. So due to time constraints, we would like to take your questions as we go along, but we also will hold 10 to 15 minutes at the end. But feel free to ask us questions along the way. So the first question is, where is CRICO's experience? This is Mark Horgan. Oh, sorry.
Thank you. Good morning. I'm just going to take a couple of minutes to talk about the insurance perspective on physician professionalism, which is a much more key issue in defending all litigation that we see than you might imagine. I think most people look at unprofessional behavior in the litigation context as a consequence of patient anger for poor physician conduct that might inspire the patient to want to take action against you. And at that level, it's very important to maintain the trust and the goodwill of your patients. But what most people don't know is that physician behavior is a key screening criteria by plaintiffs' attorneys that those patients are going to go see. What all of us do who work in litigation is try to anticipate what our case will look like to a jury. And if behavior makes a patient angry, it's likely to make a jury angry as well. And the way our cases tend to play out to a greater extent than you might imagine is the expert testimony that we all seek, whether you're a defense counsel or a plaintiff's counsel, tends at the end of the day to cancel each other out in a great percentage of cases. And really what it comes down to is the ability of the physician to defend his or her conduct in front of a panel of their peers, a jury from Suffolk or Middlesex County typically. And really what's going to happen is they're going to ask themselves, would I want to be seen by this physician? Would I want this doctor to be my doctor under these circumstances? And that explains why we win so many of our cases. I mean, we typically win 95% of our trials because we have such wonderful physicians and defendants. The cases that we don't see exemplary conduct from our defendants in, we tend to settle. We try to get a handle on what we really think that doctor's conduct was like and how they'll present themselves to the jury. You may not know, you may know us as a medical malpractice carrier. We're also an insurance company and a couple of other lines of coverage, one of which is our association liability policy that includes employment practices. So a burgeoning area of litigation in this country is workplace litigation, where bad behavior angers not the patient, but the colleague, who then turns to the court system. And the screening criteria and the decisional criteria is much the same. What's the jury going to think about the conduct that led to this lawsuit? And our assessment of the case and our willingness to defend it will turn on how we look at it. And we have a lot of different testing mechanisms, the most important of which is probably a mock trial where we hire a jury to give us an opinion as to the physician. So we try to screen out the real disasters before they get in front of the court. But that's a long way of saying that it's in everybody's interest, I think, to stay out of litigation and to follow the golden rules that we all know apply, not only in our personal lives, but in our professional lives as well. That's what I have to say about the topic. It's my pleasure, though, to introduce John Reardon from the law firm of Mielek, Porter and Shea. John is a longtime member of the CRICO panel, and probably more than any other attorney on the panel, splits his time between these two areas, medical malpractice and employment practices liability. So I can't think of anybody more qualified to speak to this issue this morning than John.
Thanks, Mark. Good morning, everybody. How are you? As Mark said, my name is John Reardon. I'm an attorney within the CRICO system. And within the CRICO system, I do medical malpractice, and I also do employment law. And as Mark said, the employment law stuff is burgeoning. All you have to do, you can watch Matt Lauer in the morning, you can watch Oprah in the afternoon. This whole topic of behavior in the workplace, bullying, how your boss reacts to other people, it's just burgeoning. People are chasing it around. And in terms of the Brigham, you may or may not be aware of some of the issues that have arisen recently here, which we don't want to get into today. We were actually involved in that case, and but that's not why we're here. It's not like the Brigham's like, holy cow, we better get something and do some training. That's not how this worked. You're all actually pretty lucky. We do a lot of training at various places, both in the medical setting and outside the medical setting. And the one thing that CRICO and the Harvard hospital system has done is take a very aggressive stance over the last 5 or 10 years to provide training on behavior in the workplace. In many ways, it's no different, and nobody looks at it this way, and they all look at me with their heads tilted when I say it, but it's really no different. Having us come in and talk about this stuff is really no different than your 401k plan, your health insurance, or anything else. Because a workplace is the most important thing. And I know, it may sound corny and it may not. But if people are working with people in the workplace that they find intimidating, that they find unhelpful, that they find threatening, that they find discriminatory, that they find overbearing, their whole day stinks every day. They don't want to go to work. They don't want to do their job the right way. And how that manifests itself in the hospital setting is becoming more and more prevalent. And not only is that, all of your professional organizations have adopted this. Whether or not it's actually true, every professional organization they're dealing with has adopted it. Every hospital now has a code of conduct. Every hospital now has behavioral policies in place. You're going to be hearing next from Dr. Shapiro, whose title, and it's going to talk to you about, is Director for Professionalism and Peer Support. The AMA has a policy on behavior in the workplace. Your professional organization, ACOG, has policies on behavior in the workplace. JCO now has behavior in the workplace as a major factor when they come in and do their audits. The policies that the hospital have set up, the way the policies allow people to come and talk about things when they complain, and how they handle those settings. So I know over the past couple of years, the Brigham has been very aggressive in having people come in and do training on this. And maybe you've all sat through it. If you haven't, there's someone checking off names as to how many people have been through this process. And it's very, very important. So the topics that I'm talking about today we lecture on constantly, and each one of them takes about an hour and a half typically. You guys are getting the, and Joe's does, and Kathy's does, you guys are getting the Reader's Digest version of it, but that's how Grand Rounds works. So let's get down to business. In my role, you've had all this great training. My role is not to come in here and threaten you or say this, this is, it's not an overbearing type approach, but the approach is tell you what the realities are when behavior becomes an issue. The other thing that traditionally is going on is that over the years, the times have changed. Everyone thinks that in the hospital setting, physicians have been allowed to be hostile, aggressive, and that was okay. And that's changing. What other people are willing to tolerate in the professional setting because they're worried about their career, they're worried about retaliation, that is all changing because of the laws and what they see as a way to protect themselves. And I'm going to go a little bit out of context here, but last week I was at a deposition in a medical malpractice case, and I was sitting there saying, this is unbelievable. So there was a nurse being deposed, and we thought it was going to be a typical, I don't remember this, and we went through this process. But within 5 minutes of the deposition starting, we heard testimony that the nurse, there were some problems with the patient. She was calling the person on call. No one was responding. She didn't want to go above that person because she was afraid of what might happen because the person's superior could sometimes be aggressive, so she wanted to stay in the chain of command. Then when the code team changed, there was a huge argument between the two disciplines who were there to work on it. And her implication was clearly, that the argument between the two disciplines affected this, or the patient care in this case. And whereas, and her willingness to take that aggressive approach is just, I don't think that behavior is new. I think stuff like that has been going on and been reported for years. But the society is much more willing to talk about it and all that because there's so much publicity about this stuff. Now, that case was a case that going into that deposition, we found to be 100% defensible, 100% defensible. And you know what? I don't think what she was saying was true. Now, that's what I do for a living, so I don't think it did affect patient care. I just think it was a high, intense situation where people are trying to do the best they could for this patient. But this whole spin on it, because of the interaction of the parties, now CRICO has to reevaluate this case and see where we go from. And Kathy's got a similar fact pattern that she's going to talk about in this case. Now we actually have, I don't want you all to feel privileged in any way that the Brigham's the only case that had, institution that has a bad case or had a bad set of circumstances going on. We have a case similar to that in every way at every major teaching hospital within the system. And maybe not in the newspaper, but in every system it's going on. And so what are the issues that come along with these cases? As Mark pointed out, it's true. Almost all of these cases from an employment perspective where you get into court has a behavioral issue. Something that a member who wasn't in that spot is going to find offensive once they start evaluating. A juror, a co-employee. Just remember, jurors are just employees. That's all they are. So when the facts of the case is explained to them, telling them about what the interaction was, they're not going to like it, and they find it offensive. So all of these cases have bad behavior associated with them. And people are willing to take things out of context, both the jurors and that, to evaluate it. But the scary part about that is that when you have these employment things, they'll sue the hospital, but they also sue the doctors individually in these cases. And when you have your medical malpractice cases, you'll have your $5 million policy through CRICO, which is a tremendous policy, by the way, because all the other insurers that we do work with, they usually have $1 million policy or a $2 million policy. Well, in your line of work, if you get an $8 or $9 million verdict against you, we can usually resolve the case with a $5 million policy, depending upon a million factors, as Mark. You have $1 million policy, you get an $8 or $9 million verdict against you, they're going to jerk you around a little bit. No Crico insured has ever paid a nickel out of their pocket in terms of bed mal. Is that right, Mark? And no one can make you guaranteed, but it's a great policy and great coverage and a great team. But on the employment side, you have great insurance too. But when you get sued on the employment side, there's several parts of that. So they're going to sue you for discrimination or harassment, whatever that case may be. That's usually the easiest thing for us to defend. Because, you know what? I don't think people discriminate for the most part. They do. I know they're out there. But for the most part, I don't think people in this day and age are saying, I'm going to treat you bad because of your religion, or I'm going to treat you bad because you're a female. I'm going to treat you bad because you're older than 40 years old. I don't think that's going on a lot out there. But what they do is they take the circumstances out there and they say, I was treated bad for the past 5 years. You're going to say it's because of performance. They were bad performers. It was a clinical setting. I had to get the darn patient intubated. And I pushed you out of the way and I yelled at you because you weren't getting the patient intubated and I wanted to save their life. So we can do some of that. We can handle the discrimination part of it. Where these cases fall apart is on the retaliation side. So even if a person makes something up, the second part of these lawsuits is retaliation. So we will defend you and we will prove to the jury there was no discrimination. And the jury will agree with us and check it off and say no discrimination. But they'll say, yeah, but after they complain, the law specifically says you can't treat them any different than before they complain. So you can win on the discrimination, and then you lose on the retaliation. And I'll use a good example. The city of Cambridge. Who's thinking anybody in the city of Cambridge is discriminating against anybody? Well, they had a lawsuit. They're discriminating against discriminators. I mean, that's about it. But in the city of Cambridge, they had a case where there was a lawsuit, a discrimination lawsuit, where an individual said they didn't get promoted because of their race. And they were retaliated against because they complained. They weren't treated as nicely. So the city of Cambridge won the lawsuit in trial, no discrimination. But the jury found they did treat this person differently after they complained. $4 million. $4 million. So no discrimination. So it's almost asking you to be inhuman, huh? So someone says to you, and it's so hard, it's infuriating in many ways, but the law says it. So someone inappropriately accuses you of discrimination, but the next day you got to walk in and say, morning, how's everybody? You like your tie? You look good today. Because you can't treat them any differently. And if they come out of their office and you're at the water cooler talking with somebody and they come out and they go, that's going to show up in a deposition. Oh, they used to talk to me all the time. Then they began shunning me. They wouldn't let me go to meetings with them. They wouldn't let me go to Grand Rounds. They used to sit next to me every day at Grand Rounds, every month at Grand Rounds. I complained. They sat across the room at Grand Rounds. Don't change your seat now if you did that. But they said, and then when all the high-profile patients came to the ring, I used to get the high-profile patients. Now I didn't get the whole-profile patients anymore. And this is how these things develop. Now, so that's the most important thing and the most difficult thing, all at the same time. Joe, this is where if you're dealing with these issues, I think Joe's going to talk to you, but she's going to be the person to talk to on some of this. How do I deal with this? But what I really want to get to on this, and this is the unfortunate part, these cases, the employment cases, always have a side. The discrimination and retaliation laws have a punitive damage side associated with them. So if they find that you discriminated or retaliated, they ask the jury, should they be awarded punitive damages because their behavior was outrageous and beyond the bounds of what should be expected. That's a nutshell of about a 20-minute discussion by the judge. But what we always tell people is that if they find you discriminated or they find you retaliated, it's not a big leap for them to find that there should be some punitive damage award given. And you do not have insurance for punitive damages. You do not, by law, you do not have, as much as Mark and team would love to, they can't even if they wanted to. So there is a personal liability, and the hospital can't, you're on your own if you get punitive damages awarded against you in these types of cases. So if nothing, as Mark said, you know, if you treat people fairly and nicely and all that, that's great. But if a case is brought against you, that is the one area of personal exposure, and no one wants to hear about that. So the other areas where this can impact you, let me just say, we talked about the patient safety stuff. It is becoming more and more of an issue in medical malpractice. You know, we've been doing this a long time. One of the slides we've been using that started about 5 years ago is that the behavior, and it was related to the nursing end of things, is that the new group of nurses coming up now, and that's probably, you hate to, you know, pigeonhole people, but I don't want to be discriminatory, but the new group of nurses coming in just are not trained to tolerate bad behavior. They're not going to accept it. They're not going to put up with it in the old days. And the perception that the person, the most, you know, really, we're getting really deep, and I got like 3 minutes left. But everyone takes the issue of harassment, discrimination, and all this bad behavior to be a power issue. You know, when you read about it, when you talk about it, it's about influencing power, not returning pages, not returning phone calls, being demeaning, taking. It's a power issue, and the medical setting is the setting in which, rightfully or wrongfully, is attributed to be a power setting. The more patients you bring in, the more revenue you have, the more experience you have, the more publications you have, the more this, the more that, the more power you have, and you're in a position to exert that power over people because they're afraid you're going to not help them in their careers. So, you know, it's just, and the new group of people coming up are trained not to accept that as an okay way to practice, and probably the result of some of the proliferation of lawsuits that we have seen. The other thing is, so often what happens in these cases, the other thing that can impact you is that when these types of allegations are made either formally in the legal setting or informally through superiors or just through PRICO through a complaint or human resources, what ends up happening is they bring in an individual like me to sit down and counsel you on your behavior. And if it's a formal complaint, again, just some specific examples that I've been involved in where administrative staff say that one in particular person is belligerent to them constantly, both in the clinical setting as well as in the administrative setting. I have to come in and sit down and talk to that individual and counsel them. Well, what happens as a result of that, very often human resources or legal feels the need to document the file that counseling has happened so that if a subsequent lawsuit comes down the path, they realize, they say, no, we heard about this, and we just didn't sit on our hands like everyone thinks we did. We actually brought someone in to work with this person. So, and I don't want to get into credentialing and moving from hospital to hospital, but that is just not something that you want to have to go through professionally. And the risk of that happening professionally now is a lot bigger than the risk of that happening professionally 10 years ago. The amount of times I'm asked to do that now has gone way up, and the risk of me being asked to come over to do that now is way up. But I don't think it's because the behavior has changed. I think it's just because the environment has changed and what's tolerated and not tolerated. So you don't want that to do. The other thing is you all have an obligation. What comes involved in all these cases is that, yeah, this doctor witnessed it, and this doctor witnessed this, and this tech witnessed it. They saw me being berated. You're going to get called in for depositions in these cases because you're witnesses. So what happens, this one says they complained about this doctor in front of everybody. No one did anything about it. So they sued the doctor, the whatever, in your case the doctor, the hospital, and then you're brought in as a witness. You were there that day, weren't you? You saw that happen. What did you do about it? What did you do? So you all have an obligation. The policies of the hospital, and Joe can talk to you a little bit of, require that if you see inappropriate behavior, you have to report it to somebody. You can't just close your eyes and look on. This is your environment. You're responsible. Morally, you want to do it anyway because you don't want this stuff going on. But actually, the hospital wants you to do it. It's part of your obligations of being here. So I'm already a few minutes over. So with that being said, I'm going to churn this over to Joe. You're going to have my contact information. Because what we do in a lot of cases, and I'm in the middle of what PRICO calls a mock trial. This is one of the few carriers that do this, and I'll just use the 30 seconds here to give you a plug for what they do. I'm in the middle of a 2-day mock trial now, and it's a medical malpractice case, but we also do it in these employment cases when there's tough issues. CRICO actually goes out, hires a jury of 15 people through a research organization, brings them in, pays them, and we're there for 2 days right now, putting on, our defendant is testifying. We have 3 of our experts coming in and testifying. We've hired a doctor to play the part of the plaintiff expert. We've hired an actress to play the role of the plaintiff who was injured during the thing. We're there for 2 days. We're having all these people testify. We're giving opening arguments, closing arguments, and then we're evaluating the jury's thought on that. My point in telling you that is twofold. One, to let you know, CRICO, and they do this often, and they do it in the employment setting, to see how will the jury react to this doctor acting this way in the workplace setting. Are they willing to accept that type of behavior? But the other reason is, though, I have to run shortly after we're done here. Typically, I'll stick around for as long as you want to answer questions. But I will be here till a little bit after 8:30, and my contact information is available also. Is that right? Yeah. Yes. Yeah. Sure.
Thank you. Okay, great.
Okay, so I think I know most of you in the room, and you all know I'm not a lawyer and I don't work for CRICO. Not that I wouldn't want to. I think they're amazing, but that's just not my gift. So I'm half the time division chief for otolaryngology here. I've been here for about 25 years, and now I'm the director for the new Center for Professionalism and Peer Support here at the Brigham. And I used to do GME for about 6 years. That's how I know a lot of you. I just want to let you know also that I'm not doing this job now because the hospital said, oh my gosh, we had a lawsuit, let's get somebody to deal with this. This actually came about over the past year, over a year, the kind of thinking that there was a need here that clinicians and researchers had that really wasn't being met. And it actually didn't come out really from the disruptive physician point of view, although obviously that's something we're going to be dealing with, and that's what we'll focus on today. But this office is, and the center is in the context of my understanding and belief after having been here for 25 years that there's not a lot of support for people doing really hard work here. There's some support, but it's just not geared to helping us do what we have to do at very stressful times. For example, when something goes wrong, we're involved in an adverse event. I don't know if any of you read there was an article in the Globe yesterday about this horrible thing with this boy who murdered his sister, and the police officers who came just as he was cutting her head off. And what they said in the article was that the police officers who got there, right as that happened, were immediately surrounded right afterwards by this stress unit that they have for the police officers. They have a stress unit for first responders, and these police officers are home now. They're getting a lot of support from colleagues. What happens to us when we're involved in something horrible? I mean, maybe not that horrible, but we do see a lot, and we bear a lot of responsibility. And I am going off here a little bit on just understanding that it's our mission to put support in place for all of us because we need it. We deserve it. It's really important to have. So that's the context of this. So this is the center, and these are some of the things that we're doing around that. But I'm going to focus on the professionalism point of view. And I think just what was being said was that the rules have changed. When I trained in surgery, I mean, it was like, I was screamed at all the time, and that was just the way it was. And I practically didn't think twice about it after a while. I mean, I didn't like it. It certainly doesn't help you learn, but it was like, that's the price if I want to be a surgeon. I have to put up with that. And that's clearly not true anymore. We know that it's over. Memo to all of us, we can't be that way. And also I want to say, and any of you who've taken the professionalism training sessions that I run, the first thing I say is that I'm not standing up in front of you because I'm the model of professionalism. I've had a bad day here and there, and I've been snarky and not been my best, and when things go really, really haywire, it's very hard to maintain a lovely rapport with everybody around you. That said, that's not what we're talking about here. We're talking about repetitive, behavior that's disruptive. That is, it's demeaning, it's humiliating, because we have enough data to know that that's a patient safety issue. It's a patient safety issue because when you're working with somebody who's going to humiliate you, or there's a big chance that they're going to humiliate you, you are not going to come forward with information, and we have the data for that. So it's sort of the train's left the station. There's no arguing. This is not a matter of, oh, I just want everybody to be touchy-feely and happy, which I do, by the way. But we want to take care of patients, and you cannot take optimal care of patients if you have a disruptive team member, and that includes, it doesn't have to be a physician, anybody who's disruptive repetitively. Or if it's not repetitive, if it's egregious. Okay, so those are the two things that we're talking about. Please don't call me for every time somebody looks at you askance. I mean, I know you won't. I'm just saying that, we can't have that culture here. That's not what it should be like here. We don't want to be paranoid that someone's going to be reporting us. But I'm talking about repetitive behavior that's disruptive. So what enables professionalism? So how come we're not all stark, raving disruptive? And I think it has to do with people's ability, most of our ability to handle really a lot of conflict and stress management. Also, a lot of us, most of us possess really amazing communication and teamwork skills. That's partly why we are attracted to doing this kind of work. And a lot of us are very empathic. We know what it would feel like to have somebody yell at us, so we don't want to do that because it hurts them and it hurts us to do it. And another thing which should never be left unsaid is that systems do play a part in our behavior. Resources, the amount of control you have over your environment, the accountability. So anytime that I hear about an incident around or a complaint around a repetitive behavior, one of the things I'm going to do is look at, sort of do a root cause analysis. How much is the system contributing to this behavior and how much is it the individual? And you know what? Usually it's multifactorial. It is. And I don't want to ever assume that it's just somebody being just a horrible human being, although sometimes it is. That is true. And that leads to the last one. There's character, and our character is immutable. My sister's a clinical psychologist, so is my brother-in-law, and they repetitively told me you can change behavior, you can't change character. So most of our characters are amazing, and that's good because they're immutable. We can't change that. But we can change behavior in people whose characters are not so fine. And here's some excuses I've heard, and they're in the literature too. Oh, the only one around here, I'm the only one who advocates for my patients. If I don't yell about this, nothing will get done. So a lot of people exhibit repetitive bad behavior because it works. The ones who yell get the most resources. So in doing sort of, again, a root cause analysis around this, we have to make sure that behavior stops getting rewarded. Okay? And the other thing is that if somebody is defending his or her behavior because he or she's a patient advocate, what I do is I give them the literature on safety, so that the outcomes for patients are worse if you're a yeller. They just are. Your team falls apart. You don't communicate. 70% of risk events occur, or of errors occur in the face of communication, miscommunication. A lot of it has to do with people having information that they're unwilling or incapable of passing on because of the way things are structured. So if you really care about your patients, you start to behave better. The others, I practice in a high-stress environment. Anyone in this situation would react this way. To me, it's the I'm special defense. And I want to go, and I don't practice in a high-stress. Of course, we all do. And nobody is special, okay, in that sense. We all practice in a high-stress environment. People need to be less sensitive. I'm not trying to hurt anyone's feelings. It's their problem if they take this personally. So the answer to that is, I'm just going to disagree with only one tiny thing that Mark said, and that is, it's really not exactly the golden rule, do others as you would have them do unto you. It really is, do unto others as they would have you do unto them. And that is that even if I am not bothered by someone yelling at me, that doesn't mean it's okay to yell. Because many people are. And that's where we get into these issues of style differences and cultural differences. To some people, to most people, being yelled at is humiliating. Okay? And it shuts them down. So just because the yeller doesn't experience that and could take it if I yelled at him or her, That's not an excuse. So within reason, this is absolutely not a fair defense. It just isn't. So as you know, everyone, for credentialing, now this is the first year it's required for credentialing. Everybody is required to participate in, I don't use the term sit through, participate in a professionalism training session. They're interactive, and it's for us to explore these issues together. Because I personally, in doing the training, I've learned a lot, and I've taken a lot of ideas back to the leadership around things that we could do to, have better support for people to behave as best they can. Then the real question is, how are we assessing it? And I can tell you right now, we're not. We weren't, but we are going to start very soon. One of the things we're going to do is we're going to probably eventually, we're starting as a pilot project, do 360-degree evals. So I'm the division chief, right? Now, Mike Zinner, who's my chair, has no idea what it's like to work for me. He has no idea. For all he knows, that all the staff hate me. And I'm mean, and I'm humiliating, and I'm obnoxious. There's no evaluation of my ability to be a leader, to be a communicator, to be a team player. None now. He just doesn't have the information unless someone complains about me. Okay? Now, for someone to complain about somebody, they are risking, their fear is they're going to be retaliated against. So it's a pretty high threshold, usually for people to complain. So we realize we can't just wait for complaints to come forth, although we have to have a system to deal with complaints as they do come forth. So a 360-degree eval is a way of getting, it's not looking at multiple parts of somebody, it's having one person evaluated by many people, nurses, residents, colleagues, people in other specialties who work with that person. And as we understand this is going to become routine, and it should be, we're going to be showing really to the community who are these, most of us will be in this category, unbelievably professional people. And you'll find they're in the most stressful positions sometimes. Okay? And by contrast, we're going to have to be working with the people who are flagged as really subpar in their behavior. This is behavior-based. It's not you to say, Gestalt-wise, yes, she's so professional. But what does that mean? It's going to be questions around, under stress, does she yell? Or under stress, is she still able to communicate well? Those kinds of very specific behavior questions. And it'll be quite anonymous, very, very user-friendly, all done through, computer survey, taking 10 minutes to do. Interprofessionalism complaints, those are complaints not about patient care, although they could be if they're around behavior. Those are, we're changing the system, but those are going to come probably mostly through me to start with, at least, so we can get a sense of what's going on in the hospital. The way it is now, people don't know who to go to. They really don't. And they may think there's only somebody in their department they can go to, and they don't want to because they're afraid of retaliation, which is totally understandable. I mean, it's a reasonable fear, even though it's illegal to retaliate. It's still a fear people have of being retaliated against. And we're afraid of it too, and we're very mindful of that when we hear complaints. And so I'm probably going to end up being the point person, just start to triage where those complaints will go and how we'll handle them. And we'll be developing more learning as we have over the past couple of years. Where are the hot spots? What's repetitive and what isn't? Okay. And the other thing is that if any of you is interested in reading literature around disruptive behavior and what it does, there's a lot out there actually. But there's a high correlation between patient complaints, interestingly, and both risk events, okay, and it looks like in this one of the studies that was done here, interprofessionalism complaints as well. So these things are related. When I hear people say, but he's a great clinician, but he's a really awful person, I'm like, I'm sorry. How can that be? And most times if you dig deep enough, it's not true. They're not a great clinician. They've got real problems in communication. So this is I put this up here because I worry about it a little bit. I mean, ideally, what I'd love to tell everybody is, and have this be true for myself, is if somebody does something that bothers me, is to be able to pull them aside in private and say, when you said that today, that really made me feel demeaned. Or it really made me feel frightened about your response. But most people can't do that because of the hierarchy that we have. And we can't take the hierarchy away. It's just, okay, there's nothing wrong with a hierarchy, but we have to know when it's getting in the way of interpersonal communications. So I do want to say that, if you can tell somebody that they bothered you, because sometimes people don't know. And one of the things that I've observed is in dealing with physicians in particular who are repetitively disruptive, a lot of times when I've been able to tell them about this, they're shocked. They really didn't see it because they just see the world a different way. And just getting the information, getting the feedback. In fact, if some of the data on giving people 360s, their information from that, can be behavior changing right there. Because if you know people are looking at how you behave and that it matters, okay, and you get the information about how you're perceived, it can help you change your behavior. So I think that will be helpful. But that said, give us all a break. One bad day, unless somebody does something horrible, okay, let's, give each other the benefit of the doubt. But we're talking about repetitive or egregious. And if you have a question, ask me. In other words, just if you're not sure if it fits in that category, just call me. We can talk about it. Just to remind you that this isn't all about punishment. It's about support. So we really are absolutely committed to supporting us all and doing the difficult work that we do. And there's many resources, obviously, not just through the center. And the good thing about the center of one so far is that, I've just been here for so long. I have such amazing people I can work with, calling people from CRICO, calling Janet Barnes if we have issues. There's so much support here. And I think we just want to pull it together so people see where it is and know that, and we will help people access the right support for them. And then if people are one of these, special peoples, Jerry Hickson at Vanderbilt calls them repetitive disruptive behavior. There are ways we have of remediating them. And the bottom line is, if the behavior continues, then they can't stay here. I can't do this job if the bottom line is everybody gets to do what they want anyway. There are going to be people, and there have been actually, who can't stay here. They can't change their behavior. Very few people will fall into that category. Most people will respond to the help and the information. So thank you for letting me join this, and I just want to tell you that we'll be getting more PR around access, that is, on a website and those sorts of things. But for now, you all know me. Just call me anytime, email me, page me if you have any issues you want to talk about. I'm really happy to. And also would love to work together on this. If you have ideas about how you think things could be better or things that are working well that you want to point out, that's always welcome. But it can be in any way related to any of this. I'm more than happy to hear. So thank you.
So before we open up to questions, I just want to highlight a malpractice case from CRICO. Again, it shows repeated disruptive behavior that played itself out in the courtroom. And we ended up having to settle the case. So let me just quickly go through the case, and then we will open up for questions. Thank you for your patience. This was a 34-year-old female with a family history of breast cancer. Her sister had breast cancer. She opted for elective bilateral total mastectomies. She wanted immediate reconstruction by a plastic surgeon. The general surgeon did the mastectomy. The preference card, as most of our cases illustrate, there's always a cascading effect of many small things kind of combined together. The preference cards were lost, so the instrument set was in standard. It happened to be a very small room that day, so that added to the tension in the room. The scrub tech leaves early because of a family emergency. The circulator nurse becomes the scrub nurse, so again, things are setting up for this event to be occurring. Circulating nurse is now covering 2 operating rooms. The plastic surgeon comes in early, and he demands, he starts yelling for immediate reconstruction. Again, there's a pattern of behavior with this plastic surgeon, as Joe mentioned. This is not something that was an isolated event, but a pattern of behavior. The general surgeon did not agree to have the plastic surgeon step in early after the first breast was removed. The plastic surgeon appeared very, very disruptive, started to yell at the nurses, saying into the general surgeon saying that you're going too slow. He remains in the operating room and demands at least 5 times for the nurse to get more Allergen for his procedure. Again, the general surgeon insists on completing the mastectomies first. So again, communication degraded, lots of chaos in the operating room. So the second part of the case leads to distraction. During the procedure, the breasts were excised with tissue, handed off to the field. Both specimens were to be sent to pathology for testing. 6 days later, it was determined the breast tissue specimens never made it to pathology. They were thrown out with the drapes due to the distraction and the yelling in the operating room. Other issues that set this case up, the surgeons had never worked together before and didn't talk about the procedure. It sort of goes to the importance of a checklist and sharing your concerns early on. There was no plan for how surgery was to take place. The nursing staff was highly stressed, given the yelling in the operating room and all the other factors in her workload. And the distraction led to the breast tissue, both sides, being discarded. The case was settled for lots of reasons. We obviously could not bring this to trial for lots of reasons. So again, I think from a practice perspective, we're seeing this behavior playing out in our cases, and that's the reason why we would like to come to talk with you about the importance of behavior. So with that, I would like to open it up for questions for John Reardon, Mark Horgan, Joe Shapiro. Are there any questions? Yes.
Joe, I was wondering, you had framed the professionalism thing in terms of a lot of negative behavior, but maybe to try to, if you could have positive opportunities for recording positive behaviors as well, positive variance and learning from that as well.
So yeah, that's a great point to everybody here. So actually, that's why I tried not to do that. So thank you for telling me that it didn't come out that way. Is when I put professionalism, what makes us be professional? It was in the positive. And so one of the things that we're thinking about with the 360 is taking the people who score highly on these and actually, first of all, learning from them. You know, there's some very interesting literature on, not in medicine, but just in general in terms of management and leadership, around how the people tend to focus on the negative when we're trying to learn about a problem. And I think what the data suggested, if you take the people who are doing very well and you study them, that would be very helpful. So I think not only for us learning from the people who do well by these 360s, but also actually making their presence known in the institution. In other words, rewarding highly professional behavior. So that's part of my dream too, is to do that. And thank you for it.
Yes.
Having gone recently to a trial, including a mock trial and a trial with different outcomes, how predictive is the mock trial of the eventual trial outcome, and is it useful in any way?
Yeah, it's useful in lots of ways. We don't think that it's entirely predictive in the sense that if we get a bad result at the mock trial, we're going to look very, very hard at a case before we choose to take it to trial. And if we don't know why the jury did what they did, and we don't believe that we can fix it, we'll settle that case. So it is, to some extent, determinative of whether we're going to take the case to trial or not. Although, as I said, occasionally we lose the mock trial, we know why, we fix it, we win the trial. It's useful not just for the predictive value, though. It's a great experience for the defendant who hasn't been on the stand before in front of 15 people, and we do it as much for that as for anything else. And it helps us basically see how the whole thing hangs together.
How do you choose the mock jury?
We have a contractor, a vendor, who knows what the demographic of the county that we're going to be trying the case is, and goes ahead and just out of the phone book gets the people with that kind of breakdown.
Patients have given me, over the years, when I'm talking many years, 40, 50 years, the same two issues, time after time. We can't get a hold of our doctor because we have to get the secretary first. And if the secretary doesn't answer the telephone, like leave a message, blah, blah, sometimes we never hear from the physician back. And this is a constant source of irritation. The second one that I hear is, why are people complaining about infections that are going on in hospitals, and all you have to do is see the people on the street wearing their operating room uniforms? And I've heard this innumerable times.
So I think the telephone issue is a big issue, trying to get through to the attending. We see it in our cases. We see a tremendous amount of breakdown in the cases. We're trying to get in touch with the attending, and we are working on trying to set expectations for when the attending needs to get more involved. Second question on infection. I think it's a policy issue with respect to wearing stuff outside. I think you raised two very good points.
In the mock trial I'm involved in right now, one of the issues in that case is that a woman came in with the size of a quarter necrotic tissue in her breast, and she said that she tried calling the doctor's office. She came in on a Monday, tried calling the doctor's office Thursday, Friday, couldn't get through, and then obviously got worse over the weekend. So that issue does come up in FICO's experience.
As you say with the patient complaints, as you know, there's a high correlation between patient complaints and malpractice. So not being available, affable, and able is the three tenets of risk management.
Well, and I think that maybe your point also is that we are dependent upon the system to tell us when someone's called, and that's why when we look into problems, we're going to look at, is there a problem with resources, or is there a problem with access, and what is that? Because it's not always the person about whom the complaint is lodged that's really the problem.
Former patients of mine, for instance, I've talked to the patients who are referred to other physicians, and they'll call me back and say, how do I get a hold of this doctor? Yeah. And his secretary won't let me get through.
Yeah, it's unfortunate. Any other questions? Thank you for your time.